Hi, this is the recorded lecture for altered intracranial regulation, including headache and seizures. So before we go any further, I want you all to know that according to ODDS and educational standards, when we are recording a lecture for a PowerPoint, we are to be reading the PowerPoint precisely. So if you do not feel like hearing me read it to you, the PowerPoint is posted and you can certainly go through the PowerPoints yourself without listening to me read them. However, this is offered so that you can look along, read along, and listen to a person reading it to you. So the objectives for this particular lecture are: the student will be able to identify the different classifications of headaches and seizures. The student will be able to identify the clinical manifestations of tension, migraine, and cluster headaches, and the clinical manifestations associated with general and partial seizures. The student will be able to describe the appropriate diagnostic tests and treatments for the patient suffering from headaches or seizures, and the student will be able to implement the nursing process with patients experiencing headaches and seizures. Headaches, the most common type, is the most common type of pain experienced by people. The majority of people experience functional headaches, such as tension or migraine headaches. Others may experience headaches due to organic cause. The classifications of headaches, they are classified using the International Headache Society, or the IHS. There's a diagnostic criteria based on the characteristics of the headache. So it could be primary, which includes tension type, migraine, and cluster headaches, which is what we're going to be talking about today. Or it could be secondary headaches, which are headaches caused by conditions or diseases such as sinus infection, stroke, neck injury, tumor. So these are the type of primary headaches that we're going to talk about. Tension, as you can see right here. Tension is often described as a feeling of a weight in or on the head, or a band and squeezing around the head. Migraine headache is described as an intense throbbing or pounding pain that involves one temple. And cluster headaches, they are a pain that is focused in or around one eye and is often described as sharp, penetrating, or burning. So the first one we're going to talk about is tension headache. It is the most common type of headache. The etiology and pathophysiology. It was originally thought that they were the result of sustained and painful muscle contraction of the scalp, head, and neck. It is believed to involve the neurovascular factors similar to those found in migraines. The clinical manifestations, there's no prodrome or aura, which means like a sensation or flashing lights or some type of hallucination that sometimes occurs prior to some type of headaches and sometimes occurs before seizures. But what you may see with someone with a tension type headache, they may develop a sensitivity to light, they may have bilateral pressing and tightening feeling, and it may occur intermittently for weeks, months, and even years. Diagnostic studies, how they diagnose this is careful history and journaling, and they may do an EMG, which may indicate sustained contraction of neck and scalp or facial muscles. Migraine headaches are recurring headaches, and they're characterized by throbbing pain, and unilaterally or bilaterally. Usually there's a trigger event or factor. The most common age of onset is between 20 and 30 years of age, and it is more common in female. The exact cause is not known. 70% of sufferers have a first-degree relative or that have migraines. Migraines are associated with seizure disorders and other neurological conditions such as Tourette syndrome, ischemic stroke, depression, and anxiety. And often there are triggers, hormones such as that occur with puberty, menses, and menopause. Dietary, a lot of times people eat chocolate, cheese, tomatoes, aspartame, which is NutraSweet, and alcohol that might trigger a migraine, or someone who's very fatigued or stressed with excessive physical exertion or mental stress. Pathophysiology, they believe there are three theories. It's related to vascular, it's related to muscle tension, and it's biochemical. Clinical manifestations, there is recurring headache by unilateral or bilateral throbbing, throbbing pain with or without a trigger. It's oftentimes accompanied by nausea and vomiting. It may be preceded by a prodrome or an aura, And the diagnostic journaling is through history and journaling. Cluster headaches involves repeated headaches that occur weeks to months at a time, followed by periods of remission. It's not as common as tension headaches or migraine headaches. It is more common in men than in women. The etiology and pathophysiology, it's rare. The cause is not fully known. It's believed that the trigeminal nerve, dysfunction of the intracranial blood vessels, and the hypothalamus is involved. Clinical manifestations are sharp, stabbing, intense pain around the eyes, temple, nose, and gums, which may last from a few minutes to a few hours and may recur many times throughout the day. The pain typically occurs around the same time each day during the same season or time of year. You may see swelling of the gums, may cause restlessness, agitation, and it can last up to 4 to 8 weeks. How do we diagnose? Through a history. They also might do a CAT scan or MRI to rule out other factors. Collaborative care for headaches. We do a history and physical. They may do a neuro exam, inspection to rule out infections, auscultation to rule out bruits over the arteries, palpation for swelling and tenderness, and they will utilize diagnostics such as MRIs, CAT scans. They will do drug therapy. So it's for tension type, they will use analgesics such as Tylenol, opioids, sorry for the misspelling, which may be some type of opioid, codeine, whatever type of opioid of choice, or they may use muscle relaxant. Migraine headaches, they will use analgesics, which would be like a Tylenol, anti-inflammatory, which would include NSAIDs. They will use triptans, which is Imitrex, and as a type of preventative of controlling the migraines. Preventative also includes anti-seizure medications, antihypertensive, also Botox injections have been known to be helpful, and antidepressants. For cluster headaches, oftentimes they use 100% O2 6 to 8 liters for 10 minutes. They also might use triptans to prevent, NSAIDs for the pain, intranasal lidocaine, and verapamil. Other types of headaches that may occur will be given analgesics, such as Tylenol. Nursing assessment will include subjective and objective data, which include, for subjective data, they will give you their past medical history of the diseases, any family history, work history, home environment, and history of headaches. The objective data would be vital signs, skin color, are they pallid, do they suffer from diaphoresis, edema, restlessness, muscle resistance of head and neck, or any hemiparesis. Nursing diagnoses, what nursing diagnoses might you have with a person suffering from headaches? Acute pain, limited mobility, impaired communication, and ineffective coping. Planning, what are some of the goals for patients suffering from headaches? You want to reduce pain or have no pain, identify triggering factors, identify appropriate coping strategies, and increase quality of life. Nursing interventions, you want to examine patients' lifestyle. You want to teach them relaxation techniques, encourage healthy dietary choices, offer analgesics, encourage meditation, and educate patient on triggering factors. Evaluation, did what were our plans or goals met? Did the interventions work? And if they didn't, we revise the plan so that we can come up with goals and interventions that are achievable. The next topic we're going to talk about is intracranial regulations regarding seizures. What is a seizure? A seizure is a malfunction of the brain's electrical system that results from cortical neuronal discharge. The manifestations of a seizure is determined by the site of origin, and a seizure can be generalized or partial meaning focal or localized. Epilepsy. Epilepsy is a condition in which the person has spontaneous recurring seizures. It's really important to remember that not every seizure is an epileptic seizure. You can have a seizure and not have epilepsy. The key difference is that a person with epilepsy has recurring unprovoked seizures. In the United States, there are 3 million people with epilepsy, and we are seeing a higher incidence in those with epilepsy greater than 60 years of age. Here is the seizure disorder in epilepsy, a little classification where they classify seizures to the left as partial and to the right as generalized, and what happens to consciousness. So typically with a partial seizure, they can be alert or have slight alterations in their consciousness. Alert with simple partial seizures and some alterations with complex. With generalized seizures, you probably have altered consciousness which especially with the tonic-clonic or absent seizures, and brief or possible altered consciousness with myoclonic, tonic, clonic, and atonic seizures. Clinical manifestations, typically it's determined by the site of electrical disturbances and divided into two major classes, which are generalized and partial. Clinical manifestations may progress through several phases. What we have is a preictal phase, which will include before the seizure. You may have a prodrome phase, which is a phase that precedes, and it's kind of, you might have a warning as to the activity that might be coming, or an oral phase, which is very similar to what I talked about with the headaches, like with the migraine, that you may have a bright light, something's going on, smell, something that pre-warns you that a seizure is going to occur. The ictal phase is the phase of the actual seizure activity. So you're in full seizure activity at this point. And the post-ictal phase is post-seizure activity. So generalized seizures. Generalized seizures are characterized by bilateral, synchronous epileptic discharges in the brain from seizure onset. With a generalized seizure, you will have no warning or aura as the entire brain is affected. Sometimes people will say they have an aura before they have a generalized seizure, and if that's the case, they typically have had a focal or local seizure that progressed to a generalized seizure. So there is loss of consciousness from seconds to minutes. So generalized seizures, they're called tonic-clonic seizures, formerly known as grand mal seizures. These are the most common and most dramatic type of seizures. They go through a tonic phase and a clonic phase. The first phase is the tonic phase, and where there's stiffening that lasts about 10 to 20 seconds. It occurs without warning. You'll see the eyes of the individual roll upward. They will have a loss of consciousness. They will fall to the floor. Their body stiffens in generalized symmetric tonic contractions. Their arms become flexed. Their head, neck, and legs extend. They may exhibit a high-pitched cry. They may become cyanotic. They have increased salivation and loss of swallowing reflex. They progress then to the clonic phase, which can last from a few seconds to as long as a half hour. In this phase, or the clonic phase, it's violent jerking movements as the trunk and extremities undergo rhythmic contraction and relaxation. You may see them foam at the mouth. They may become incontinent of urine and feces. As the seizure ends, the movements become less violent or intense, and the interval of jerking slows and then stops. Tonic-clonic seizures, again, grand mal. In the postictal phase, which is post-seizure phase, it is characterized by muscle soreness. Obviously, if you're seeing them become very tight and then jerking, you're going to have muscle soreness, fatigue, and you may see the patient sleep for hours. They may not feel normal for days, and they do not have a memory of the seizure. And as you can see in this picture, in the tonic phase, they become very tight, and in the clonic, they're jerking. The muscles are jerking. Other generalized seizures that you may see or hear about are typical absent seizures, formerly known as petit mal. And you still may hear both those seizures that we just talked about, the tonic-clonic and the typical absent seizures, referred to still as petit mal or grand mal, but those are typically old terms. But the typical absent seizure occurs only in children and rarely into adolescents. They may cease to develop into another type. They may cease or develop into another type. The typical symptoms is staring spells for only a few seconds and usually can go unnoticed. You also might see with this a brief loss of consciousness. The person's not aware of it. It can occur up to 100 times a day if untreated. An EEG usually demonstrates a pattern unique to this type of seizure. It is often precipitated by hyperventilation and flashing lights. An atypical absent seizure, which we just talked about the typical one, but an atypical absent seizure is characterized by staring spells with other signs and symptoms. You will have brief warning, peculiar behavior during seizure, and confusion after. So there might be a repetitive seizure that they don't remember doing. Other types of generalized seizure is a myoclonic seizure that is characterized by sudden, excessive jerk of the body and extremities. It can be forceful enough to cause falls. It's brief, it happens a few seconds, and may occur in clusters. And there are people who have myoclonic epilepsy, and they typically exhibit these quick excessive jerking of the muscles bilaterally. And an example of what it might feel like for a person who has monoclonic epilepsy or has a myoclonic seizure is similar to when, if anybody has experienced falling asleep and all of a sudden you have a sudden jerking of the body and extremity as you're falling asleep. That's referred to as a myoclonic hiccup. It's not a seizure, but people with myoclonic type of seizures experience something similar to that experience of what you have, or what you might have occurred when you're falling asleep. Atonic seizures involve atonic episodes of paroxysmal loss of muscle tone, and the person falls. So what happens is the muscle just loses complete tone. A person falls, and by the time they fall or hit the ground, the consciousness usually returns, and they can resume normal activity. However, these patients are at greatest risk for head injury. Other types of generalized seizure, tonic seizure, that involves onset of increased muscle tone. Patient often falls and is confused after it occurs. Clonic seizures, which begins with loss of consciousness and sudden loss of muscle tone, followed by limb jerking. Clinical manifestations of partial seizures. So partial seizures are referred to as partial focal seizures, and they are caused by focal or local irritations. It begins in specific regions of the cortex. It may be confined to one side of the brain and remain partial or focal in nature, but some may involve the entire brain and accumulate into a tonic-clonic seizure. Partial seizures are further divided into simple and complex partial seizures. Simple motor or sensory phenomenon with elementary symptoms, with no loss of consciousness and lasting less than 1 minute. Partial seizures divided into simple, complex, again, with complex involve behavioral, emotional, affective, and cognitive function. It is the most common complex partial seizure involves lip smacking and repetitive movement. You will have alteration in consciousness followed by a period of postictal confusion. Oftentimes you will hear it referred to as psychomotor seizures. Psychosensory symptoms in partial seizures may occur during complex partial seizures. That is, the person experiences distortions of visual or auditory sensation. They may have vertigo. They may have alterations in memory and alterations in thought process. Common causes of seizures. Common causes during the first 6 months of life are related to severe birth injury, congenital birth defects that involve the central nervous system, infections, and inborn errors of metabolism. Etiology and pathophysiology, that common causes on people ages 2 to 20 are still related to birth injury, can also be related to infection, trauma, or genetic factors. On those, the causes on those between the ages of 20 and 30, typically structural lesions, trauma, brain tumor, or vascular disease. Common causes after 50, cerebrovascular lesions, metastatic brain tumors. However, in all cases, 75% of seizure disorders are considered idiopathic. The role of hereditary in seizure disorders is difficult to determine. However, some families carry a predisposition in the form of low threshold to seizure-producing stimuli. We also see, of course, trauma, disease, and high fever are the seizure-producing stimuli that some of us may have a higher threshold than others in having a seizure, and we see that that is familial. So if someone has a high fever and they have febrile seizures, that someone else in the family probably in the past has had the same type of thing. In epilepsy, there are abnormal neurons undergoing spontaneous firing. The causes of abnormal firing is unclear, but firing spreads to adjacent or distant areas of the brain. If activity involves the whole brain, generalized seizures occur. It is believed that seizures have a higher incidence of being triggered by changes in electrical activity in your brain during certain stages of falling asleep and waking, and that sometimes is a period of time that you're very vulnerable, especially a newly diagnosed epileptic or someone who just started having seizures. A good time for them to be leery of possible seizure activity is when they're falling asleep and when they're waking. Complications for seizures. Status epilepticus is a state of constant seizure or condition when seizures recur in rapid succession without return to consciousness between the seizures. This is a neurological emergency, and it can involve any type of seizure. It used to be described as a seizure that lasted longer than 30 minutes. However, now they have it classified as a seizure that lasts longer than 5 minutes, is classified as status epilepticus. Sometimes what we have in the notes below is there are what's called a subclinical seizure, and that's a form of status epilepticus that can occur in a sedated patient who seizes, but without external signs because of the sedating medication. So one example would be a patient who is sedated for ventilatory support in the ICU, but could not experience a seizure they experience it rather without physical movements. And that could be very dangerous, obviously, as well. Complications of status epilepticus causes the brain to use more energy than is supplied. The neurons in the brain become exhausted and cease to function, and permanent brain damage can result. We had said that the status epilepticus can occur with any types of seizure. The one that is the most dangerous, obviously, is the tonic-clonic status epilepticus, because it can cause ventilatory insufficiency, hypoxemia, cardiac arrhythmias, hyperthermia, systemic acidosis, and also trauma during the seizure can cause severe injury and death. Other types of complications that can occur with seizures is that there is a social stigma that occurs oftentimes with people who have epilepsy or people who have seizure disorder. It interferes with the value of self-control, with conformity and independence. There's also discrimination oftentimes in employment and education system, and there are driving sanctions, so their independence is definitely taken away. So some diagnostic studies, accurate comprehensive description of seizures with the patient's health history. So someone who's witnessing the seizure can give a comprehensive description. An EEG, an EEG is typically used, but only a small percentage of patients with seizure disorders have abnormal findings with the first test. So they'll need to do continuous monitoring with an EEG to make sure that they're able to decipher any abnormal electrical activity. They also would do a magnetoencephalography in conjunction with the EEG. This has a greater sensitivity for detecting small magnetic fields generated by neuronal activity. They may do CBCs, serum chemistries, liver and kidney functions, and a UA to rule out any metabolic disorders. They will do a CAT scan, MRI in new onset seizures to rule out structural lesions, and other types of scans such as cerebral angiography, spectrometry, a magnetic resonance spectrometry, a magnetic resonance angiogram, and a PET or a positron emission tomography in selected situations. What can we do as nurses? Neurological assessment we would want to do, and that would involve testing for nystagmus, which is involuntary eye movement. And as you can see in the picture, it's the eyeball kind of going back and forth sideways, shaky. Hand and gait coordination, cognitive function, and general alertness, which we always do, right? Alert and oriented times 4. We are aimed at preventing. We can't cure most seizures through medication, but drug therapy is aimed at prevention. What we want to do is stabilize the nerve cell membranes and prevent epileptic discharge. The choice of which drug is dependent on different factors. So it will be dependent on the type of seizure, the frequency of the seizure, the EEG results and other tests, the medical history and the presence of other conditions, the lifestyle and age of the patient, and if female, we want to consider the consideration as to pregnancy or nursing, because some medications could be dangerous to the baby in utero, or to the baby once you're nursing. Medications may be used alone. They may use one medication, or they may find that a combination of several medications work better. And 70% of patients who receive medication are controlled with medication. What is very important is we need to make sure that these patients monitor drug serum blood levels. Common medications that you may see used in people who have a seizure disorder are hydantoins, which are Phenytoin or Dilantin, that's used for partial seizures and tonic-clonic. Carbamazepine, which is Tegretol, and that's used for both partial and tonic-clonic seizures. Valproates, or valproic acid, which is Depakote or Depakote. That is a first drug of choice for partial and generalized seizures oftentimes. Barbiturates, phenobarbital for tonic-clonic seizures. You're not seeing it prescribed as often, but they still do use it. Benzodiazepines, which is lorazepam, Ativan, diazepam, Valium, or Diastat. These are the drugs of choice for status epilepticus. And you'll see when you are on the schools that oftentimes the student, when they go on a field trip, if they have a seizure disorder, the nurse accompanies the student with a Diastat suppository to help take care of a seizure if it happens on the field trip. Succinimide or Neurontin is a drug of choice for absence seizure, and gabapentin, Neurontin for partial seizures. Side effects of most anti-seizure medications, which, of course, outside the CNS, the patients may describe that they are experiencing rashes, hyperplasia of the gingiva, blood dyscrasias, and there can be some effects on the liver and kidneys. One of the things with the hyperplasia of gingiva is something that we see quite frequently, and you want to make sure that they give good dental hygiene, including regular toothbrushing and flossing. Collaborative review, gerontological considerations. Phenytoin may be problematic for older adults with compromised liver functions. So they may be using the newer anti-seizure medications, which offer a better treatment for older adults, such as gabapentin, levetiracetam, lamotrigine, trileptal, topiramate, and zonisamide. They will be drawing on all patients with anti-seizure medications. They will be monitored serum levels. Most medications have a therapeutic range, and the blood may be drawn a few days after initial treatment and every 2 to 3 weeks after. They may do surgery for some types of people who have surgery. The benefits of surgery include a reduction or sometimes a cessation of frequency of surgery. But the disadvantages is that not all types of seizures can benefit from surgery. It may not work. So requirements for surgery, how they would decide that they're going to do surgery to help this person would be they need to have a diagnosis of epilepsy confirmed. It can't just be one seizure and let's do a surgery. They need to have adequate trial with drug therapy without satisfactory results. So they've tried the drugs, it doesn't work. And they have to do an electroclinical syndrome, meaning the electrical impulses. There's some type of syndrome that's occurring, and it's defined. Other care that they might do for people who have epilepsy or seizure disorder, diagnosis of are vagal nerve stimulation, which gives intermittent stimulation of brain to reduce frequency and intensity of seizures. Biofeedback to control seizure. It teaches patient to maintain a certain brainwave frequency that is refractory to seizure activity. And also ketogenic diet, which consists of a diet high in fat and low in carbohydrates. And that has been successful in many cases of childhood major seizures. Some of the nursing assessments. You want to assess if the person has presented with a seizure. Do they have any birth, especially in pediatrics, do they have any birth defects or injuries at birth? Do they have any anoxic episodes during birth or some other time with some type of injury? Any central nervous system trauma? Are there any tumors? Do they have any metabolic disorders? Is the person an alcoholic? Exposure to metals or carbon monoxide? Do they have any hepatic or renal failure? Are they compliant with anti-seizure medications, barbiturates, or are they going through alcohol withdrawal or cocaine or amphetamine withdrawals? We also want to do a family history. Do they have a history of headaches, aura, or mood or behavioral changes before seizure? Do they have any anxiety, depression, loss of self-esteem, social isolation? Decreased sexual drive, erectile dysfunction. Do they have any metabolic acidosis or alkalosis? Hypokalemia, hypoglycemia, dehydration, or water intoxication, which can all be cause seizures. In the ictal phase, which means during the seizure, do they bite their tongue? Is there any soft tissue damage? Any cyanosis? Do they have an abnormal respiratory rate? Or apnea, which is stopping breathing. Absent or abnormal breath sounds? Or do they have any airway occlusion? Is there hypertension or tachycardia or bradycardia? Bowel and urinary incontinence, excessive salivation, weakness, paralysis, ataxia, or abnormal CAT or MRI or EEG. Nursing assessment during these particular different types of seizure, tonic-clonic, you will see loss of consciousness, muscle tightening, then jerking, dilated pupils, hyperventilation, then apnea, and the post-ictal phase, they will be somnolescent. Absent seizure, altered consciousness, minor facial motor activity is what the nurse will say as you're assessing it. A simple seizure, they might have an aura, focal sensory motor cognitive or emotional phenomena, unilateral marching, motor seizures. For complex seizures, we might see altered consciousness with inappropriate behaviors, and they will have amnesia of the event. Some nursing diagnoses: ineffective breathing pattern, risk for injury, ineffective coping, and ineffective self-health management. Planning. The overall goals are that the patient will be free from injury during seizure, have optimal mental and physical functioning while taking anti-seizure medication, and have satisfactory social functioning. So what are some of the nursing implementations during a seizure? You want to stay with the patient. You want to maintain a patent airway, ease the patient to the floor. This is if they're, of course, having one that they lose consciousness. Protect the patient's head. Turn a patient to the side. Loosen constrictive clothing. Do not restrain the patient. If the patient is in the hospital pad side rails, never attempt to put anything in the patient's mouth, such as an airway or tongue blades or fingers. Assess the patient for dilated pupils, excessive salivation, altered breathing, cyanosis, flushing, diaphoresis, and incontinence of urine and feces. You also want to record the seizure time of onset, characteristic of body parts involved, seizure progression and duration, and time seizure ended. Once the seizure is ended, you're going to monitor the patients in the postictal phase, which is post-seizure phase. You want to monitor their vital signs, their pupil size, the position of the eyes, their breathing. You want to apply O2 and or suction as necessary. You want to monitor their level of consciousness, their memory loss, any speech disorders, any weakness or paralysis, any muscle soreness, behavior and overall fatigue. Patients often are exhausted and go through a sleep period. And you want to document your findings and durations of your findings. Nursing implementation, prevention of injury and avoidance of possible triggers, and patient education. So what you're going to do if someone is very frequently having seizures, you would encourage them to wear a helmet, especially if there's a risk for head injury. You want to encourage good health, eating habits, and dietary habits. You want to assist to identify events or situations precipitating seizures and avoid if possible. You want to instruct to avoid excessive alcohol, fatigue, and loss of sleep. You want to instruct the patient to avoid driving or other types of activities such as swimming, climbing, or riding a bike until seizure-free for at least 6 months or longer, until anti-seizure medication is within therapeutic range, and until cleared by a doctor.